Let's see here. Okay, wait, I gotta close my packs. Make sure I have no PHI anywhere. Getting error messages everywhere, standard. Okay, let's try this again. Grab my screen, share, monitor 2. Let me move this over here. So this is a case I was just, oh, the brain never came over. Just shown, and I think I might have, it's an older case, I think I might have shown it a while back, but I can't find any history of me having it downloaded, so maybe I didn't. But this was a guy who presented with, and I was trying to show his brain MR, just strokes everywhere. I mean, his brain MR is the fusion is more white than normal brain on. It's just horrible. And he underwent a ablation a few days earlier, and he actually, during his stroke CT that he got, so he underwent ablation, he had a stroke. He had a stroke CT, and they go down to the neck to look at the carotids, and they caught in the left atrial appendage, and you can see this gas layering in the left atrial appendage, not a ton. And it was picked up, and they mentioned it and said it may be through a PFO. You know, neuro people, I mean, again, I think us as cardiac imagers would know what this could be, but I think it's, it was good to pick it up because it was subtle, and it said, you know, recommend further imaging, and they got a CT, and you can see there's marked thickening around the esophagus, and then this little dot of air that's kind of adherent, or, you know, along the wall here. You can see the thickening not only the posterior wall of the atria, but the esophagus still finds a little dot of air. The gas in the appendage is gone. He unfortunately just died a couple of days later. He also had massive troponin elevation and severe dilation, and presumably, I'm guessing, he threw air bubbles into his coronary arteries as well. So this was, and unfortunately, we didn't recognize this little dot, and I think it's, you know, if you have someone with a history of stroke, status post ablation for AFib, you know, just look for anything that would point to an aortoesophageal fistula, because I think that diagnosis was delayed a couple days. So just a nice example of that.
Do you mean aortoesophageal or esophageal?
Sorry, atrioesophageal fistula, sorry. Sorry, yeah, atrioesophageal. Thank you for correcting me on that. This is just a case of, which one is this? Yeah, this is, you know, as Travis would say, an iatrogeny case, where this guy presented, he had around the descending thoracic aorta, you can see there's an extraluminal area of, and I have the non-con, but to save time I won't show it, this increased attenuation surrounding the aortic arch, and you know, you can see it around here in descending thoracic aorta. And they just put in an aortic balloon pump, and the person had severe chest pain when they put in the aortic balloon pump. And if I can get this to scroll through appropriately, you can see the kind of aortic balloon pump had injured the wall. Let's see if I can find the little, there's a little rent somewhere, if I can find it with the scrolling through. Here it is. So you can see there's a little abnormal, there's no vessel that comes off there. So presumably when they put up the intra-aortic balloon pump, they put a little divot into the wall, went through the wall, or at least through the intima, and caused an IMH. So I've seen a lot of intra-aortic balloon pump injuries. I don't know, and I'm surprised I don't see it more, a subsequent IMH from an intimal injury from that. This case is a great case. I was trying to pull up the tissue mapping, which I have, but it's just, I couldn't do it in time. So you see, this is a youngish kid. You see he's got an AICD in, and it's pretty remarkable image quality for the AICD. And don't ask me what our technique is, because this next week, the same day we did a study, the next patient also had an AICD, and the image quality was horrendous. So I think it's just pure luck. But you can see the LV is hypertrophied. There's normal function. It's really circumferentially hypertrophied. And, you know, you're in a differential diagnosis. Is he, you know, he's got a systemic hypertension. You know, is he got a hypertrophic cardiomyopathy? We know some cases of HCM are diffuse. Does he have some other infiltrative process? And I'll just show it on the 4-chamber. If I can get this to run, maybe I won't be able to. But you can see myocardium is quite thick. And then the best part is the delayeds. So you can see here, very nice classic hazy mid-myocardial enhancement, specifically in the inferolateral segment, really at the base extending to the apex. And, you know, it's very beautifully elucidated on the 3-chamber view as well. And this is just absolutely classic. And so very nice, you know, very happily that the tech did the tissue mapping. And the tissue mapping wasn't as low as I you know, have seen with this process. It was around 750 milliseconds on a 1.5T, and around 1,000 is normal. So it's an accelerated or faster native T1 relaxation, which it only happens in 2 conditions. One is hemochromatosis, which this isn't, and the other happens in Fabry's, which we know leads to basically fat deposition within the myocardium, leading to the more rapid relaxation on native T1. And for some reason, I don't know, I don't think anyone knows, leads to this classic enhancement in the inferolateral segment at the base. So a beautiful example of Fabry's. And again, only the second one I've really seen. And which case is this? That one's that one. This one's, which one did I not show? Oh, this is just, you know, I envy you guys, and I will say this without trying to talk the least amount of crap I can. If you have good pulmonary pathology at your institution, like really good, just be grateful. When you see them, thank them, tell them we're wonderful. Just say, hey, you know, it's a pleasure working with you. I know some of you guys work with some of the, you know, really big names, and I had someone at Maryland, and, you know, Jeff Galva's wife I could always send stuff to. So here was a case of someone came in, young girl with this lesion down here, and it's vascular around the edges. And the central portion it's soft tissue attenuation, because of the degree of vascularity. You know, they were worried about, could this be some, I don't even know what they were thinking, but you know, the differential was this more of a posterior mediastinal lesion in the you know, neurogenic origin? It was a little, usually those are back here, but I've seen them this far up. Or is it a some sort of potentially foregut duplication cyst? You know, there's some other weird things you can think of. It's not avidly enhancing, so a lot of those kind of strange things like you know, Castleman's and paraganglioma are felt to be unlikely. So I thought this was going to be a foregut duplication cyst, and it was taken out, and it was read as a teratoma. And I'm like, whoa, that's crazy. I mean, I've seen a lot of teratomas, and yeah, we know that teratomas don't have to have fat, but I've never seen a posterior mediastinal teratoma. And if you look it up, there's a couple case reports, but you know, again, you always wonder. So I was like, I just don't buy it. So I had another pathologist here pull up the study, and within a second, you could see that this whole thing was just lined by respiratory epithelium and cartilage. And I'm guessing the reason that they called it a teratoma is they saw cartilage and just said, oh, it must be a teratoma. But it was a classic bronchogenic cyst with lined by respiratory epithelium, and the cartilage they saw was just, you know, cartilage you can see, that was respiratory cartilage that you can see in these. So a little bit atypical location. We know they're more on the right because of the way the aorta is, and also they just happen to be more, I'm guessing, more on the right. But anyways, I don't think I've seen one that's vascular, but they get infected, had a lot of feeding vessels, they embolized it before surgery. But definitely not unheard of in this location. But that's it.
Thanks, Seth. And I think that's a good point, is anytime you have they do this in breast imaging, right? If they have discordance between the biopsy and the imaging, they look at it again. And
yeah.
And sometimes it just is what it is, but sometimes, yeah, if you go back and look at the path or have a different opinion on it, you get a totally different result.
Yeah, no, the pathologist said, oh, well, it's still benign. I'm like, yeah, but it's nice to have the right diagnosis. But I do it, you know, with our ILD cases.
Right, we do that all the time.
And if there's an explant, you know, someone comes here for the outside imaging, they get an explant. I just had a case today where they read it as chronic HP, and I'm like, man, this does not look like chronic HP from an explant. And, you know, we review them then in our path conference, like we do a radiology pathology conference, and we review them together, and sometimes they change. So.
Yeah, oh, absolutely. I saw one recently that was NSIP pattern on CT, and the biopsy was read as UIP, which is fine, but it was done somewhere else. But then all I see mentioned in there's all this chronic inflammation, which to me raises red flags. It's not going to be IPF. Yeah. So hopefully we'll get a chance to look at those slides. But all right, excellent. Well, thanks. Let's see, David or Peter.
I've got a couple, Jeff.
All righty. There you go. So hopefully we'll get GoToMeeting will behave today.
Okay. So I am sharing a röntgenogram here that shows a man with lung cancer. You can see his mass medially here on the right, and you can see a lytic lesion here in the scapula if you're lucky. Showed it better on some other imaging, and maybe some other little nodules floating around here. So this is an advanced lung cancer case, and he received our new therapy protocol here, which is to use these ROR1 sensitized CAR T-cell therapy, which you know, attacks this ROR1 you know, antigen, which is prominent in some tumors. So we've seen this with breast cancer. I showed a case a couple of weeks ago where it was used for breast cancer. It's also used for lung and some other cancers. Unfortunately, this antigen is shared on a lot of normal tissue too. So when they infuse these very aggressive T cells, you can get quite a lung reaction. So this man had cytokine release syndrome, and here's what his chest radiograph looked like after he got this CAR T cell immunotherapy. You can see he's developed diffuse lung disease, and here it is on CT with lots of septal lines. So there's clearly an edema component. So perhaps it's just a capillary leak from this cytokine release, and it's hard to know how much lung damage there is along with that. So if it reverses fairly quickly, then it was just a capillary leak that was still retaining, you know, keeping the large molecules, the protein inside the bloodstream, and it wasn't a lot of alveolar damage. But he was fairly sick, and it persisted for a while. So this is some cytokine release syndrome. This is kind of what you expect with these CAR T cell, and part of it is probably the attack on healthy tissue, on lung tissue, for instance, not just cytokine release from the T cells, but probably an immune attack partly on lung. So hopefully you're looking for a therapeutic index of having the tumor cells more sensitive than the normal body cells to this ROR1, this attack on ROR1. So you know, he's still in the ICU, still short of breath and stuff like that, and we've not had a repeat CT to see how things are evolving and how much lung damage there is here from therapy. So part of the immune therapy response is this cytokine release syndrome. And this guy, it's fairly hairy. So he was intubated for a while, but he's been extubated. He's probably getting a little bit better. Okay, so ROR1 CAR T cell therapy. I don't know, are you using CAR T cell therapy at your institution, Jeff? Are you seeing it?
Very uncommonly. I think we see it, is it lymphomas I'm seeing it for?
Right. So the traditional CAR T cell is directed against lymphomas and leukemias, so things that are lymphocytic.
Yeah, I haven't seen it with solid tumors.
Right. This is the new thing, and there's a special protocol. So I think right now this is all protocol led. It's not really out there, I think, released for general. So you guys have seen it first here. So stay tuned.
That's some pretty crazy paving too. It's really aesthetic.
Way crazy. Yeah, that is crazy paving.
Yeah.
Okay. Okay. Let me show you this case.
There's not much septal thickening around the in the right upper lobe, around the where the cancer is.
Yeah.
So just right upper, maybe the superior segment of the lower, right around there.
It's pretty asymmetrical. I think it probably reflects where the blood is going, and because of the big cancer here centrally,
Yeah.
I think more of the T cells are being delivered to the other side, just
Yeah.
because mass here. Okay, and there was one chest radiograph earlier this week that looked to me as if there might be a tumor response. The tumor seemed to be getting to be shrinking down on a chest radiograph, but the next day, with different rotation, it looked about the same. So I'm hoping for another CT that shows. I'll be able to show you maybe in a couple of weeks some tumor response. That would be lovely. And just to verify the scapular metastasis, here's that destroyed scapula from metastasis. Okay, let me show you this this case of some gut. This is colon, it turns out, in a strange location, sort of straddling the lower chest. We just have AP imaging there. On CT, let me show you the scout view from CT. You can see that this is posterior here, or fairly posterior. So if this is some sort of a diaphragm problem, it's in the posterior part, so we might be thinking about a Bochdalek hernia. And here's what it looks like on cross-sectional imaging. Indeed, there is a big piece of gut here coming up, and it's posterior. Now, the imaging is clearest on the sagittal reformatting here, that this indeed is a very large Bochdalek hernia. So here is the diaphragm going here, and then here is the stuff streaming up through the hole in the back of the diaphragm. So this is a big Bochdalek hernia with a big chunk of colon in it. I'll show it to you on, see, we get down, here's diaphragm. As we work our way back, we lose our diaphragm muscle, and still we get this herniated fat and colon here. And this is a bit of the hepatic flexure that's gone up there. And we've got contrast, then dense contrast in the colon elsewhere too. So a very big Bochdalek hernia. This is bigger than usual. And when they're big like this, it's kind of hard to figure out at first what's going on. You know, where is this coming from? Where is it going? But then, particularly with the sagittal imaging, I think it becomes clear that this is a Bochdalek hernia. Okay, so a nasty Bochdalek. Okay, Jeff, those are the one show.
Peter, do you have cases?
Yeah, I got a couple also.
All right.
And she had a cardiac mass that was seen incidentally on an abdominal MRI at an outside hospital, and then the outside hospital, they did a cardiac MRI also to look at it, and this is the mass here. It's in the, looks like it's involving both the ventricle, the left ventricle, and the and probably kind of going out towards the pericardium, but it's well circumscribed. This is T1, so low signal on T1. T2, also low signal on T2. Another T2 image here, low. So low on T1 and T2, and this is the perfusion. So you can see it's taking up contrast. and post-contrast images. Just a T1 post-contrast with CODSAT, and you can see pretty homogeneous enhancement and very homogeneous enhancement on the late gadolinium enhancement. So we also did a
Hemangioma.
okay.
It's a good look for hemangioma. I've also seen a bunch of fibromas. I've never seen, again, a bunch means like 8. Just not that common. The ones I've seen are always bigger, and they're always more in the meat of the ventricle. They're not at the apex. They're more commonly, they're just bigger. I mean, it could be, it's possible, but that enhancement, the delayed enhancement works. But it's more cystic. So the two things I was thinking is either I've been fooled once by when there's like a little pseudoaneurysm, like a little LV pseudoaneurysm, which can happen anywhere, and it looks like a mass, and it's just a piece of myocardium that's, or whatever, a piece of LV that's kind of contained, or a hemangioma, or
it's
others.
It's not a pseudoaneurysm. We also, I didn't show it, but we also have a cardiac CT of it.
Okay. So I think with the enhancement pattern, I'm thinking something quite vascular. So yeah, that was my initial thought, but I don't know. I mean, again,
yeah, I mean, we thought about hemangioma also, but it's on the T2. Wouldn't you, with the hemangioma, wouldn't you expect to see
yes,
spontaneity or something like that?
Yes and no. It depends on the type of hemangioma, right? Because we have ones that have a lot of cystic spaces, and then you have ones that are very tightly packed with vessels. So it depends, but yes, I mean, actually, when I said that initially, because you popped it up, I said, oh, it's gonna be hemangioma. He said, well, wouldn't that be right on T2? And I said, yeah, you're right. I mean, that's the thing that's a little odd, but I have a lot of fibromas, and they don't perfuse like that.
I mean, that didn't make sense to me either, but yeah. So what would you recommend? I mean, would you
splitting it to take it out, and then we figure out what it is.
Take it out?
No, I'm just saying, just so we can figure out what it is. I agree, it's probably never going to cause a problem. I don't know the best way to find out. But wish we had path. That'd be nice to know.
Yeah. Okay. And then this is just a quick one. This was on a this patient is this was a this is the chest CT part of a coronary calcium score. So so this is basically incidental finding, middle-aged female. Any thoughts for you guys?
Sarcoid?
Yep, exactly.
Yeah, nice sort of tiny little nodules mimicking ground glass opacity.
Yep. It wasn't, so it wasn't the immediate thing I thought about, but then I opened the chart and I saw sarcoid, and that made a lot of sense. But it's not, not the most classic look.
No, and as we've learned, well, we know, and I should say, as we've reaffirmed, sarcoid can do a lot of really crazy.
Yeah. And I decided to show it because I got it right after you guys showed all those cases of sarcoid last week. So
yeah, this one looks like you have some trying to be the old fairy ring sign, which is sort of like a reversed halo or atoll sign, but it consists of tiny nodules, which was described years ago, and it doesn't come up very often. But it kind of has an OP look, but then you realize it's not pure ground glass; it's tiny nodules.
Mm-hmm.
That's nice. So I guess it was a screening coronary, no symptoms.
Yeah, and then history of sarcoid.
Cool.
So the reason that sarcoid is ground glassy is when the nodules don't cohere into the larger macroscopic nodules that we start to be able to see on CT. If you're just dealing with the tiny little granulomas that are in the alveolar septa and stuff like that, they're spaced out, and the CT is just going to register ground glass.
Right.
Not going to see the individual microscopic nodules. So, I think there are certain situations in which sarcoid is less cohesive, doesn't cohere to the bigger microscopic nodules that we view as the classic CT findings. And I have a feeling that some of the secondary sarcoids, the ones in response to like Humira, the case I showed 2 weeks ago, are more likely to have that diffuse ground glassy, less cohesive nodular look to them. So there's so few cases of the secondary sarcoid or sarcoid-like reaction that I have that I can't really generalize, but it strikes me that a number of the ground glassy cases of sarcoid have been in that situation.
And David, I think what also supports your point about the sort of the lack of cohesiveness of the nodules or coalescence is when you see sarcoid that gets treated, and as it starts to resolve, if you do some imaging, the nodules go from sort of the well-defined ones to more ground glassy. And I think it's just the granulomatous inflammation kind of melting away, and you just see less and less of it.
Got it.
All right. Is that it, Peter?
That's it.
Awesome. Okay. I got several I can show. We'll end a little early today, but I got quite a few this week. So I'll go through the little ones here. Okay. Where shall I start? We'll start with a nice iatrogeny case, or iatrogenosis imperfecta. This is one of the better ones I've seen with a tube misadventure. So this patient was transferred to us with a drain in, and still had a persistent air leak and pneumothorax. You can see it's really bad emphysema. And you come down here and you see this funny little structure here in the superior left lower lobe. It's got a fluid level in it. It's pretty dense material there, so it looks like blood, and there's some junk around it. And you can follow this tubular tract right to the fissure, and then it crosses into let's see, we're in the upper lobe here, and you see this pigtail sitting right in a space in the lung, and then you can follow this pigtail along this little tract out to the chest wall. So here's the sagittal, and you can see there's this drain going into the right upper lobe, just sliding along, and then the pigtail formed. I suspect one of two things happened. This was, I don't know if this was a trocar mounted one or if they used a guide wire. I suspect this was probably trocar mounted. They probably placed it in here, given the size of this and the hemorrhage around it. And then they retracted it a little bit after they formed the pigtail. And I think it just created a tract, and then it's staying right here. So a completely intraparenchymal chest drain that actually crossed the fissure. And you can see how far out I think they went originally. But there was a case like this when I was a fellow in Vancouver years ago, where they actually managed to get it into the trachea by sliding into a major airway, and then it just took the path of least resistance. So after that case and whatever they did, they made the decision to ban all the trocar mounted chest drains from the emergency department because it's too easy to skewer the lung, especially when there actually isn't a pneumothorax. The case back then was a collapsed lung that the emergency resident thought was a effusion. I wish I may have that case somewhere. If I can ever find it, it's great to show. But anyway, just an example of that. So the CT is, in this case, can be helpful in figuring out why their drain isn't working properly. This is something I don't think I've seen in a really long time. So this is a young man who presented a little bit short of breath, and this was his initial radiograph. And it doesn't really show much of anything. And then he got sick later on, and he developed, this is about 2 weeks later, he had all these little nodules here. So at the time, we got a diagnosis of HIV, so we thought this was going to be some kind of miliary infection, either fungus around here or TB. So he had a CT scan at that time, which shows all these kind of tiny nodules and then some septal lines and some more confluent stuff, not really looking like a pneumocystis picture. He's got pleural effusion. And so he was a new diagnosis of HIV, which we found out at the time. But what we didn't know is he had already been started on treatment. So this was actually when he presented and was started on treatment. His CD4 count at the time was like 50. And this was after heart therapy, and his count started to recover. So in retrospect, I think this is a good example of immune response inflammatory syndrome, or IRIS. And then here's a subsequent CT done later on. You can see all those nodules just kind of vanished as edema went away. So I mean, you can't really prove it through a biopsy, but the fact is as his counts came back up, he had some kind of immune response, and then it sort of cooled itself off. So a case of iris. I don't think I've seen one I may have seen one when I was a resident. It may have been in a teaching case, but I haven't seen one since. I don't know. Have you guys ever come across this much anymore?
I haven't seen one in a really long time.
When I was an intern at our county hospital, where we have a big HIV population on the medicine service, they were the ID people. They always talked about it. So I think clinically they run into it, not too uncommonly. But it's hard. It's hard to, I think, from a radiology standpoint, it's probably just hard to pinpoint.
Right. And when I first learned about it, the thought was it may be immune response to some pre-existing antigen like a mycobacteria, because it really it looks like two things. It looks like some edema, but it also looks like miliary disease. So anyway, well, that was the good news, is it wasn't anything bad.
Jeff, isn't that still the assumption that you're actually lighting up some infection that's in the lung?
Yes, that's my understanding. Or yeah, because with the CD4 count as low as his was, there's not much of an immune response that can occur until you recover your counts.
Yep.
I think that his initial chest radiograph already showed a diffuse, mild lung disease. I don't think that was a normal.
Yeah, I thought
that's cystis or something, for all I know. I can go back.
Yeah.
Yeah, he's so thin. It's hard to say on a little screen like this. It looks pretty good on my screen, but you can make out some vessels. But yeah, we don't have anything else at that time. I don't have any cross-sectional to prove it one way or the other. But yeah, so he got better. This next case is another infection case. This one highlights the value of, I think, thoracic radiologists and, more important, conversation across services. So these are all outside imaging, and this is what happens when the freight train starts, and sometimes you can actually stop it. So this is a young guy. He's like 20. He's a farmer, and had some chest pain or cough. So anyway, got this CT on the outside. And they commented on this mediastinal mass, which you can see in the subcoronal space. And if you look carefully, there's some faint little calcifications in it. And then right here is more calcification. And there's some hilar nodes. Let's see, they're a little bit lower, I think. Yeah, there's like a bronchial node down there, and then another node down there. And then they noticed this nodule here on the right lower lobe. And this is one of my favorite findings. So when I see a big nodule with a bunch of little nodules around it, especially if they're marching along the lymphatics, which are usually the nearby veins, for me, I'm very happy with this being granulomatous infection, typically histo in this part of the country. I've seen it not with blasto, but I have seen a cocci case look like this, but histo seems to be the big one. But the fact that the draining lymphatics are out of proportion to that nodule as far as the extent of them, like that subcranial node and this calcification, and it tells me it's probably subacute. But of course, they hear mass, what do? They order a PET CT, which I still argue is, for most cases of nodules, is a complete waste of time and money. And it ends up resulting in bad things happening more often than good things. And of course, this thing lights up like a light bulb, and there's a little bit of activity in that right lower lobe nodule, but it's so small. I mean, this is just the fused image, but the SUV in that was much lower than here, which is well known in granulomatous fungal infection, the flip-flop sign, as I've heard people call it unofficially. And so they were getting ready to do a VATS biopsy of this thing or something, but somehow I came across it at one point and talked to the appropriate people. And so they sent off the appropriate urine antigens and serum antibodies, and guess what? They're all positive for histoplasmosis. So no surgery for this guy, which is a good thing because he's a farmer and this is growing season. So even with a VATS, you're out of commission for a while. So just because it lights up on PET does not mean it's lung cancer. You got to look at your pretest probability. First of all, he's 20. And then second of all, the morphology is so key. So this finding here for anyone watching this webinar is this dominant nodule with these satellites that tend to march along the lymphatics, and MIPS can be really helpful to see this. I can thicken it up a bit, but yeah, you you can see all this little nodularity along there is pretty classic for histo. I've not seen it with mycobacterial disease, but I don't see a ton of it. And I have not seen it, as I said, with blastomycosis. I don't know, do you guys see this a lot with the cocci on the West Coast?
No, the only cases I've seen, I mean, initially I thought it was going to be a bronchogenic cyst, and then you showed the other stuff. I'm like, oh, you showed cases of this before.
Exactly.
And I've not seen this with cocci.
Okay.
At least I have not. I'm sure Dave has more experience than I do.
No, I have not seen it with cocci, but I haven't looked. So I'll keep my eyes peeled.
All right.
I see that with histo here all the time. We have a good amount of cases of that exact thing finding.
Yeah, somehow this one doesn't belong in there. I have to delete this. So this is a trauma case, but I'm not showing it for I must have mislabeled this one. This is not the one I was interested in. So I will just skip that one.
What kind of farmer was that guy?
This was one. This what? I'm sorry?
What kind of farmer was he? He was a big boy.
Oh,
Just like-
I'm guessing corn because I think he was from Illinois.
Yeah.
So when we cross the border out of Wisconsin into Illinois, it's almost all corn farms up there. They don't really have the dairy farms. This is kind of a cool case. It's a trauma case, but the reason I'm showing it is it shows something that we see a lot that we don't talk about a lot. So we've all seen this biapical sort of pleural thickening and calcification. And these aren't asbestos plaques. We see it sort of in older patients, and it's just some scarring. And I don't ever give it much thought, but what caught my attention on this case, so this guy had a trauma. He fell at the gym. He's like 80 years old, so good for him for being at the gym. But unfortunately, he must have fallen on a weight something because he trashed his chest wall pretty bad. But what it shows, we have a pneumothorax here, so we can see that this thickening and calcification has separated from the chest wall. So I think what this shows is that first of all, it's on the visceral pleura and not the parietal pleura. And I think most of the finding is probably not pleural, but in the parenchyma. And I think that rim of calcium is pleural, but the stuff underneath it is probably just scar in the lung. But I've never given much thought about it, and I don't think anyone really knows what that is. But I thought that was interesting to see that he had this.
So, Jeff, I had some cases I actually been collecting, and I was going to show them at the conference, including pneumothorax, that showed that this was visceral pleura that's calcified. You know, I think it goes, and the interesting thing is the lung is not adherent to the chest wall, so it's not much of an inflammatory thing. I think it's probably a kind of, I'll bet you it's an ischemic injury to the lung, you know, at that way up there at the top and stuff like that. It's a very thin shell. It doesn't cause any adhesion. You know, it's just very benign and very indolent looking. So, you know, all sorts of things happen at the lung apex. You get scarring there. You get little bullae that form there. I think there's some trauma associated with hanging and having, you know, some stretch on the tissue, and then probably not getting very much blood supply way up there that far north. Blood just isn't getting there, and it's usually older people, as you said. So that's another thing that makes me think it might be ischemic. This person doesn't have the bullae up there or any scarring underneath. No,
he was a fairly healthy guy.
Yeah.
But and to your point about the ischemic injury, yeah, I remember. I mean, back to Jeff Galvin's lecture, he has a great picture cartoon that shows that the alveoli in the lung upper lobes are under the greatest tension because we're upright most of the time, and they're always open. And he has like a picture of a little weight hanging from the lungs. So think of it like a slinky, right? If you suspend a slinky, the top part of the coil stretches and the bottom coil is kind of compressed.
Jeff, I have a slinky hanging in my office. Is that the one you're talking about? I've got it. It's right next to me here. I'll take a picture and send you a slinky.
It's the same slinky I remember from the 1980s. I don't think they've changed much. And but that's the way I've always thought about it. I didn't know you had one in your office, but that's hysterical that you do.
Well, it was probably there in the 80s, so it's pretty old. I should dust more often.
All right, so that was kind of fun. This is something that I think I'm surprised how many people still don't know about. I know you guys all do. This is I can't remember how old, but not a particularly old patient. And what's interesting is I noticed that the cartilage or the calcification, not even just of the cartilage, but of the wall of the bronchi was quite exuberant for a relatively young person. We see this in older patients, but even not to this extent usually. And even the trachea was less involved. So my hunches were right. I said, I bet this patient's on warfarin. And sure enough, this patient had been on longstanding warfarin. And this is a known, I won't call it a complication, but a known association with long-term warfarin therapy is calcification of the tracheobronchial tree. And I know there was a nice case report out of University of Washington back when I think I was a resident. I think Eric Stern and someone did talking about this, and that was the first I ever heard of it. So I've always remembered that. And I dug around a little bit, and it does apparently interfere with a certain protein that has to do with vascular calcifications and calcifications in general, and it's a vitamin K pathway. So the warfarin, of course, blocks the vitamin K. So it does that as well, and that leads to the calcification. It's a harmless thing usually, as far as I know. I can't find anything that says otherwise. But when I see it in a young person, it always tips me off they may be on warfarin, which sometimes brings you to some important clinical information you may not be aware of. I mean, sometimes they have a valve or something, but maybe they've had strokes, maybe they have they've had PE in the past. So sometimes it can help you explain something you're dealing with or find something. But this was one of the better cases I've seen of warfarin associated. I mean, you just see how dense that is. And what I found interesting is it goes all the way around. It's not just the cartilage. It seems to involve a little bit of the posterior walls. So I guess if it gets exuberant enough, but like here, you would expect it to spare posteriorly if it's just cartilage. All right, this is a little cute case, one of my favorite type things. So a congenital tracheal bronchus. And what I liked about this one is not the tracheal bronchus, but the blood supply. So I've shown cases where they have tiny little lobettes with their own tiny little pulmonary artery branch. But this one, the pulmonary artery branch is actually kind of cool. So here's the right pulmonary artery, and then there's this little branch that comes off right in the mediastinum and slides just behind the main upper lobe pulmonary artery, and it goes up into this lung right there, which is right where this tracheal bronchus supplies up in here. So it sort of has its own separate supply off the right main PA before it even gets into the lung, that then slides in here and supplies this little segment. And it's a replaced apical segment because we got the anterior and posterior, but this is a pretty exuberant, pretty sizable tracheal bronchus here, and you can see it's kind of dipping under the azygos, which is one these like to do. But I don't recall ever seeing one with its own pulmonary artery coming off like that, other than a tiny little one that may supply a lobule or two. And then this case is crazy. You're going to have fun with this one, and I'd love to see what you think about it. So let's see, this is the one we got first. So this is an outside study, and I'm looking at this and like, what the heck is going on here? So clearly this is supposed to be a contrasted study, and we see there's contrast in here in the azygos vein, but you see all what looks like this shaggy calcium around the aorta, but then you realize quickly that this can't all be calcium. And if you look at it on sort of a softer window, you realize there's a lot of collateral vessels in the mediastinum, but I have never seen this degree. It looks like it's almost vasovasorum, and it even mimics coronary calcium. It's tracking in the right atrioventricular groove there. And then, so there is another study from just a few days before that clearly shows this is not calcium. So here we got a much better timing. So this, I didn't have any history at the time. It just said evaluate clot. Well, that's not real helpful. But after digging around a little bit, found out this guy has sickle cell disease, and he has some known thrombi. And so I'll show just the different phases help us sort of tease out what's going on. His SVC is pretty tight down here, and he's got this, he's got a port in. So presumably there's some kind of stenosis there, but clearly there's not calcium in the aorta or in that right coronary system. So he had a neck CT done at a different time, close to it, that you can see there's actually thrombus in that left brachiocephalic vein, and it extends into the SVC right there. So he had it. So that there is thrombus in there. It's really hard to see. Well, you can't see it at all in this series, really. I mean, whether that's thrombus or mixing, I wasn't confident because you got unopacified blood coming in that direction. And then I think this is just unopacified blood here in the azygos, mixing in from below. But have you guys ever seen this kind of collateralization along the, I guess it's vasovasorum. I don't know if it's just running along the aorta like this. I mean, it goes up into the neck vessels, coronaries.
And he has all that bronchiedema too in the subcutaneous tissue anteriorly. That wasn't there on the other CT.
Uh,
I had one recently in a Fontan patient. It wasn't as impressive as this, but it was pretty darn impressive. This is,
yeah, it's like,
Yeah, this is,
like an SVC syndrome. But
I thought it was.
I think that's what it is. As like SV, well, we have a good amount of sickle cell patients here, and usually not that impressive, but they oftentimes get fibrin sheets, or they have lines all the time in their
Right.
subclavian. SVCs are always occluded, so you just get collaterals all the time, but usually not that impressive.
yeah, it's just,
So Jeff,
yeah.
Jeff, I just wonder whether with that stenosis that he has in his cava, that he has had some degree of SVC syndrome going on all the time, and then you suddenly acutely worsened it and flooded it, but you probably had some dilation of collateral pathways already in place that just then became very intense with the acute.
Yeah, I think so. I think the lower SVC stenosis down here, because see here we have a lumen, then it just kind of vanishes, and you can maybe make out a little bit around this catheter. I suspect that's chronic, but I think the new clot in the brachiocephalic in the upper SVC, which turns out this is what this is based on the neck CT. Yeah, so you had to piece all these scans together to sort of figure out the timing, but I think this is a fresher clot, and I believe he had an upper extremity DVT or something to go along with this. So he's just clotting off the venous. But we're gonna get an MRA, MRV on him, I think, because they want to figure out the full extent of everything on one study and figure out what to do about it. But yeah, that was just crazy. I've just not seen that kind of collateralization, especially in that distribution. It was just weird. So, okay.
Does he have anything going into his left atrium? Any of that contrast?
Let's see. Yeah, but it all seems to be. Let's try to change the other phase. Doesn't appear to be.
No.
I'm guessing these are some bronchial veins down here, but yeah, it's just. I think it's all going systemic.
Yeah.
All right. Well, that is it. It's almost the hour anyway. So great conference, guys, and enjoy the rest of your week. I'll talk to you later.
Great cases, guys. Thank you.
Yep.